Hello and welcome to Riverside Talk. My name is Denise Mananis and I am the Associate Vice President of External Affairs for St. John's Riverside Hospital. And today we are very excited to speak to a urologist on staff at St. John's by the name of Dr. Thomas Rechtschaffen. And we're going to be speaking about prostate cancer screenings and advances in treatment. It is a hot topic and it's also a personal one for me, having had someone in my family who had prostate cancer. But before we begin, I would like to just acknowledge my team, Olivia Hunter, Candace Cousins-Hopkins, Jason Latore, and Nancy Anabi, without whom we could not put these programs together and bring them to you. So thank you to my team. And now let me introduce our speaker today, Dr. Thomas Rechtschaffen. Dr. Rechtschaffen has been in practice for over 20 years now with the Advanced Urology Centers of New York, and that's across the street, and specializes in urinary difficulties, pelvic pain, interstitial cystitis, not easy to say, recurrent UTIs, enlarged prostate, prostate cancer diagnosis, and the treatment of advanced prostate cancer. His mission is to be current with leading-edge diagnostic and treatment options as they emerge, including next-generation sequencing in UTI management, MRI fusion prostate biopsies, genomic and germline testing in prostate cancer, and innovative nerve stimulation procedures for urinary frequency. I think we've come a long way since my family dealt with prostate cancer. He is amongst the most experienced in the UroLift procedure in the New York City metro area, which is the procedure that is the first of its kind for the treatment of the symptoms of an enlarged prostate. He is the president of the American Urological Association New York section, president of the New York State Urological Society, and was a 2016 American Urological Association Gallagher Health Policy Scholar. So Dr. Rechtschaffen, thank you for being with us today. You and I are old friends. 25 years you've been with St. John's. Absolutely. It's a little shy of what I've been here, but you know, we all grew up together, so it's wonderful. So thanks for being with us again. Let's get right into our conversation. In 2012, the United States Preventative Services Task Force gave prostate cancer screening a grade of D, claiming it should not be done as the harms of screening and treatment outweigh the benefits. Why did the committee come to that conclusion, and what has changed since then?
Thank you, Denise. So that was really a big pivot point for all of us, patients and doctors. So traditionally, the treatments for prostate cancer in the 1970s and 1980s primitive compared to what we have now. We didn't have PSA, we didn't have MRIs, CAT scans were rare. So men would often be diagnosed when it already had spread. So the doctor would send the patient to a urologist, he would go through some terrible barbaric treatment, not be cured, but also suffer all these side effects. So the doctors that were training back then had a very grim view of prostate cancer.
Right.
These were now the doctors on this committee that were charged with deciding if Medicare should pay for prostate cancer screening. They used data from the 80s and 90s. They were primarily from Scandinavia and Minnesota. So the first point is there are very few men of African descent who live in these areas.
That's true.
And then the U.S. made health policy excluding that one group we know that may have higher risk for prostate cancer. Also, the screening tools were much different back then. The way we interpret PSA, the availability of all these other tests that we have now. So it bore no resemblance to what actually was happening on the ground in 2012.
Okay.
And these doctors, again, had sort of grown up in a different time, and their intent was to somehow stop prostate cancer screening. By the way, this is the same group that in 2010 had said, stop doing mammograms.
Oh.
And there was a huge uproar over that.
Yes, there certainly was.
Misinterpreting the data. They also went on the myth that prostate cancer is slow growing in all cases.
Oh, that's a myth?
That's a myth. People die of something else with cancer, not of cancer. Because the way they said it was the screen did not save any lives, implying that this is not a deadly disease. Turns out just the opposite was true. A lot of men were dying in the screening and non-screen groups. So in fact, we should have been screening even earlier in these men. We then had to have a huge grassroots campaign to change people's minds, both the government's minds and other doctors' minds, because they bought into this.
Right.
And thank God it did dovetail with a number of advances technologically in screening and treatment around that time.
So there were a couple of things in there. So that the myth, I want to just hit on that myth because my father died 20 years ago. He had an aggressive form of prostate cancer. It was caught early, but there was not a lot that they could do. They were just beginning to do some new things. But I have also heard that most prostate cancers are slow growing and that you will die of something else with prostate cancer. And you're telling me that's a myth.
I would say statistically most are slow growing, but not all.
Okay.
So there are about 200,000 plus new diagnoses of prostate cancer in this country every year.
Wow.
It's the leading cause of cancer death in men.
It's the leading cause, not lung cancer.
Well, close to lung.
Close to
It's
lung.
one of the top two, certainly.
Okay. Higher than colon?
For men. Wow. And so it's important to find those men that will die. About 30,000 men die a year. So we're looking at 15 to 20% of the men who get prostate cancer will die of it. So that's a small number, but not very small number.
Okay.
So it's important for us to be able to
Not
identify.
if it's you.
Right. Well, exactly. It's 100 or 0 if it's you.
Yeah, right.
Percent. So we do have ways now of figuring out which men are in that group or the other group.
Right.
But to assume that all prostate cancer is slow growing is wrong and dangerous.
All right. So the bottom line of that is that the screening should happen, and the screening is with the PSA and a digital exam in the urologist's office.
So PSA is important. I think digital exam isn't always needed, and I think that's one of the barriers for men to seek screening.
Okay.
They don't want the exam.
Okay.
What I do typically now, and all my patients really, is if PSA is elevated, there are a number of reasons why PSA may be
So
elevated.
let me stop you and just say, well, let's define PSA so people know what that
PSA is
is.
a blood test. It's the best blood test we have to determine prostate cancer before symptoms occur.
Okay.
Okay. The problem with PSA is that it's not transferable from one patient to another. So someone's high PSA may be low in somebody else. So what makes PSAs high or low has to be looked into.
Okay.
You look at the size of someone's prostate from a benign growth.
Right.
It's not cancer. How old they are. Is there any kind of family history or extra risk factors someone might have that might affect?
So you're looking
their
at a
risk?
whole patient.
Right.
You're looking at the whole history, and you do the PSA. So explain what you're looking at in the PSA.
So the PSA is elevated in prostate cancer.
Right.
But it's all elevated in different things. Some men have a lower PSA and still might have prostate
What's
cancer.
a normal range?
So the traditional range has been 4.0. If it's above 4.0, you're in trouble. If it's below 4.0, you're just fine. And that was the problem with the studies that the task force uses. That's how they defined it.
Okay.
And it's not the case.
Okay.
So if someone has an enlarged prostate because they pee all the time, that can have a higher PSA where someone...
But it's not necessarily cancer.
Can't, exactly.
Okay.
Whereas a man with a smaller prostate with maybe a normal PSA might have prostate cancer. So we do a division between the PSA itself and the size of the prostate. It gives us a number called PSA density, which is one way of looking at PSA to be a little more accurate.
So if your prostate is regular normal size and you have a normal range PSA, you still might have prostate cancer? I'm never going to sleep again. These are not, is that possible?
So the way we've been able to figure that out is with an MRI. So
Okay.
an MRI is a special kind of X-ray that looks at the prostate.
Okay.
The finger test and ultrasound doesn't compare to the accuracy of an MRI. The MRI will tell us the size and shape of the prostate to the first point, and will tell us if anything within the prostate looks suspicious.
Okay.
If it looks suspicious, they give it a grade, and then we recommend a biopsy.
All right. Before we go there, how old do you have to be to start doing these screenings, to start getting a PSA and coming to see
In general, without any family history or other risk factors based on your age, your country of origin, usually around 50.
around 50, unless your father had it?
So if there are cancers that are related to prostate cancer, which include prostate cancer, breast cancer, colon cancer, and pancreatic cancer. If any of those cancers are in your family, you are at increased risk. And therefore we would probably...
For men and women?
Well, for any man who has that in his family,
Okay,
right?
then
Obviously,
it was for prostate.
if,
But
if his mother has breast cancer or had breast cancer, he's at higher risk for prostate cancer. So for those men, we typically start to screen at age 40.
okay,
Okay. If their mother or father had one of those cancers and they've been tested for called the BRCA gene,
Yep.
the RCA gene, and
Yep.
that's positive, we also start screening earlier, sometimes as early as 35.
okay,
Certain, we know that men who have Western African origin have a higher risk of prostate cancer. For some reason, Jamaican men have a high risk of prostate cancer. People from Scandinavia, Sweden specifically,
okay.
and Eastern European Jews all have higher risks for prostate cancer.
Interesting. Okay, so that's quite a gamut. So people really have to be aware,
Right.
men have to be aware of everybody in their family, mother breast cancer, father prostate cancer, colon cancer, and that should help them determine when they should start having these
Right.
conversations with their physician.
Right.
Okay. So now I'm that patient or my husband is that patient and I want to bring him in and he has the PSA. And the PSA is normal, but his father had prostate cancer now, but everything looks normal. Do you recommend the MRI?
Well, if the PSA is low and it's okay, I would watch it. I would
Okay.
explain to them, obviously you're in a risk group and we're going to watch you closely. Probably do your PSA every year,
Okay,
just to make sure it doesn't move.
okay,
Another thing we look at with men who've had previous blood tests is how does the PSA behaving? If it goes up a little bit every year, no problem. But if it jumps from one year to the next, that's another sort of
Red
reason
flag.
to
Okay.
move on and get an MRI.
okay. Well, that's interesting. So the MRI test and its use for prostate is new? How new is that?
So I've been doing it for about 11 years.
Okay, so not that new.
But still, most urologists, or at the time, weren't doing it. More urologists are doing them now. But 11 years ago, I was one of the few people doing it on a regular basis.
Okay, so, all right, so then step after the diagnostic part, which we talked about PSA, MRI, now you have someone sitting in front of you who has been confirmed to have prostate cancer. So the next step, or you have things that are telling you need to look further.
Right.
What's the next step? There's
So-
something you're doing now on biopsy.
Right,
That's
so-
pretty interesting. So what's that?
So I do something called an MRI fusion biopsy.
Okay.
So someone has the MRI, there's something that looks suspicious. They go to sleep.
Okay.
Nothing is done awake anymore.
Oh, that's
Unless
lovely.
there's some reason they can't have anesthesia, everyone's asleep.
Is it a general anesthesia?
It's
or
like
is it-
it's like having a colonoscopy.
Oh,
You're snoring, you're out,
propofol
you're breathing on
kind
your
of
own,
thing?
yes.
Oh, that's
but you're not
lovely.
feeling anything.
we like that.
Yes,
Okay.
absolutely. That's the
Yeah.
way it should be done.
That's correct.
I have a very nice machine which takes the MRI data, and I can see it on the screen and overlays on my prostate image that I have with the ultrasound, and I can target exactly what they saw on the MRI.
Okay.
And this is done not through the rectum anymore, but through the skin, which then brings the infection rate pretty much down to zero, called transperineal. So it's more accurate, it's more comfortable, and it's safer, because the old way,
Certainly that psychological
Right.
of, I don't want to do that
Right.
feeling is
Right.
overcome.
so a lot of those barriers for men to get this done should be gone.
Okay.
And this is really in response to what the task force had said, that, hey, even the biopsy is a pretty rough procedure for a lot of men, and it's dangerous in some cases. You have to make it better. And this is our response. Much more accurate. So it's probably triple the accuracy. So if, God forbid, something's there, I'm going to find it. But at the same time, if I biopsy the area and it's negative, you can feel much more confident that you do not have prostate cancer.
Very interesting. So one way or the other, you're getting a good report, or you're getting real knowledge based on exactly what this is.
Right, much more accurate report than we used to
Yeah.
get only with the ultrasound.
Okay, and it's even more accurate than the ultrasound,
Right.
obviously. So you're actually getting okay. So now let's say that they get bad news. So it is prostate cancer. So what happens now?
So I have him come to my office. So I tell this story every time. When I first started in my 30s, I didn't know anything. I had an older couple there from the old country, and he was about 80, but he was a strapping man, very strong, and he had prostate cancer. And I said to them, this is the story. You need to have treatment. It's treatable, but we need to treat it. And he thanked me and said, I understand everything, but I don't want anything done. I feel good. And I repeated it again. He gave me the same response, and I looked at his wife, and I knew she wasn't going to say anything because that generation,
That's correct.
he was in charge. I said, fine, let me see in a couple months. We'll talk again. About 2 days later, I get a very angry, screaming phone call from his daughter. How dare you not treat him? He has prostate cancer. What are you doing? I said, that's not how it went down. She says, that doesn't matter. He's not in charge. I'm in charge. So ever since then, I always involve the adult daughter in every conversation.
That's very
whether they're in the room or on speaker.
Yes.
And I tell everyone else to do that when I give lectures. So anyway, so we're sitting in the room talking about prostate cancer. Most men will have a milder version, one that's not likely ever to spread.
Okay.
Maybe a 5 or 6% chance over their lifetime.
Right.
So for those men, we can typically offer either a mild treatment or something called active surveillance, where we just watch it. We'll follow the PSA, we'll do an MRI in a year, we'll make sure they get their other things in check, their cardiovascular health specifically.
Right.
And a lot of men, interestingly, have a wake-up call, and they start to eat better, they stop smoking, they drink less. So they actually get healthier, at least from a cardiovascular standpoint, because of this diagnosis. But we talk about that, and we have other tests now that also will confirm that it's low risk beyond just the appearance.
So you're taking in the biopsy and you're looking at the type of
Right.
cancer it is? Because
there are genes in the cancer tissue that they can look at that they know are good or bad. So we can get a pretty full report on their actual risk long term.
Right.
And based on that and based on their overall health and their age, we can decide what treatments are best. If they have a little more of a higher risk tumor, which has not spread yet, but might in a few years, then we can have discussions around that. And the treatments are much better than they used to be.
So, it's very interesting. My father-in-law had prostate cancer, and the way they dealt with it at that time I think it was in the late 80s, was to do a prostatectomy. And that caused some other lifestyle issues. And then my father had it, and they said he was too old to have a prostatectomy, although he was in good shape physically, but that he had the radiation, the seeds, and that worked for a little while for him. He unfortunately had an aggressive form. So I guess what I want to know is, in those days, this is already a very long time ago for both of them, what are the offerings now? So you said you can watch it and see how they do, and if you know exactly what kind of cancer, and it's a slow growing and it doesn't seem to affect them, and but for the other folks who either have that but want to treat it, or the people who may have a different form of cancer, what's available? What's in the bag of tricks?
The two still major tried and true treatments are surgery or radiation.
Okay.
Now the surgery is now done. It's a much better surgery. People go home the next day.
Wow.
A lot of the side effects.
It's robotic. And
so the incisions are tiny, maybe quarter to half an inch, not the whole huge
opening
shark bite we used to do.
Yeah.
And men typically go home the next day, and it's about a 4-week to 6-week recovery. The recovery is better. So the healthier a man goes into the procedure, the less likely he'll have to have side effects.
Right.
So that's why as men get older to a certain age, the math flips. And the benefits of surgery over radiation changes depending on your age.
Okay.
So if a man's going to live 15 to 20 more years, surgery is typically slightly better, statistically.
Yeah.
If a man is already 70, the radiation is probably the better choice.
Okay.
And there are all different kinds of radiation. There's stereotactic, there's the more standard radiation, there's the seeds. Beyond that, again, there are a whole new slew of treatments. Some men will opt for focal treatment. So The argument is if only one area in the prostate is cancerous, could we treat just that one area?
Right.
Well, we can. It's still a little bit evolving, and we usually do that only in men with the milder versions.
So you can actually eradicate with that focal radiation on the prostate just to deal with the lesions that are there.
Yeah.
I had another question and I can't remember what it is. Oh God. Okay. So keep going.
Right.
We talked about radiation and I know what it was. So for the surgery, the old surgery before the robotic, there were compromised tissues because it's in such a tight area,
Right.
an awkward area in the body that there can be nerve damage in the old way. And so there are potentially incontinence, impotence, those sorts of issues. But with the robotic surgery now, are you seeing better outcomes for that?
So what's nice about the robotic surgery is that you have a camera that magnifies everything.
Right.
In the old days, we were operating in a dark area. We could see, but maybe not as well. So the ability to spare the nerves,
Is much better.
is better. Again, men who come in healthier with
Do
better
better.
function, whether urinary or sexual, will do better on the other way out. You're not going
Okay.
to come into this with a lot of problems and expect it to get better. But we do have treatments for both those problems if you do suffer from them.
Okay.
That will work.
That's interesting.
So I hate when people avoid procedures because of these potential side effects.
Right.
But they're important. We take them very seriously.
Yeah.
So part of your recovery will be specifically focused on those functions as well. Because most people say, look, just get the cancer out of me. I don't care.
Until
Then
they
2
can't
years later
really-
and they're
right.
healed and they have issues in the bedroom. So we take that very seriously.
Wow.
And we address those as well.
Okay. All right. So I'm just looking here. So we talked about surgery and radiation. Chemo, is that a treatment that
So really up until about 2007, we
Okay.
didn't have chemo for this. If you had spread or recurrence,
Yeah.
we had very little offer, and your life expectancy was
So
very
chemo's
short.
now for spread.
Right. So now we have a whole slew of treatments, medications, pills, shots that aren't chemo that work even for spread.
Is that immunotherapy?
Immunotherapy is one of them.
Okay, so tell me all of it.
So we do have treatments that turn off the body's testosterone,
Oh.
which will sort of shrink the prostate and starve the prostate cancer. But sometimes the cancer will mutate
Immune.
and become immune to that. So we have other things that we can do. We have medicine that will directly impact the cells. We have an immunotherapy where we teach your body to recognize prostate cancer as an infection. So it attacks it with the immune cells. It's 3 shots over 5 weeks, and it works for the rest of your life. Chemo is reserved for men who have a lot of spread, but we have better chemos for it now that work very well. So even men who come in, unfortunately, to my office with already having a spread, I feel much more confident and calm that I can treat them and get them better, and get them back to their normal life. Didn't exist, 15 years ago even, yeah.
Yeah. I'm thrilled to hear all of this. I wish that it had been then, but that's really amazing. What do you attribute all of this progress to in this field?
Well, I think we were at a point where the robotic surgery, the robotic machine became very popular, and everyone wanted one. But that wasn't the right move because we were over-treating a lot of men and possibly under-treating other men. As the medicines have evolved, as our understanding of how the cells, prostate cancer cells work, that's helped.
So there's been research and
A lot
money
of
put to
research.
research for it.
So
Very
whether it's the
interesting.
genomic testing on the tumor biopsy you did, genetic testing like the BRCA genes, we know which men need which medications or treatments, and we've changed how we're
So
addressing it.
you actually can match based on that information the kind of medicines and treatments that you're doing
Yes.
that will be the most effective?
So
Oh my God.
It's much more individualized for each person.
That's fantastic.
And this is available to almost everyone, not just the big medical centers either. We have here available all that stuff for our patients.
So it sounds very much like prostate cancer, which was a very scary sort of, here's what we can do, and it's kind of limited, and our understanding was sort of limited, is now become something that is not just treatable, but you can live with it well. You can deal with even side effects of various
Right.
well. And so what are the prognosis that you're seeing in your patients that are coming now who have prostate cancer? What's
So
going
again,
on?
so we're able to better stratify men who don't necessarily need treatment for their cancer because it's so mild.
Yeah.
So that group of men now avoid all the side effects potentially of treatment. We know now the men who, even though they look great today, there may be some aspects of their genetics or the tumor
That
that
they
are
should be
scary.
monitoring.
So then we put them into better treatment earlier on,
Okay.
so they'll live longer. And then we have the middle group where we have, again, lots of options for them.
Right.
So at the very least, by putting the men in the right sort of grouping, we give them more appropriate treatment and therefore, I think, better and more effective treatment.
And better outcomes.
Yep.
So do you have a great story of a patient that was looking one way and then somehow has managed to come a long way, putting you on the spot?
No, I have a number now of patients who, again, 10 years ago, I wouldn't really have given them any hope. So a lot of men will show up, not a lot of men, but men who show up who already have a little bit of spread. So it's in the prostate, but it's also a little bit beyond. Now we have a test called a PET scan, which is literally 5 years old. We didn't have it before. They've had PET scans for cancer for a long time, but not for prostate cancer. And now we have one for prostate cancer. It's very accurate because the older methods, they weren't as accurate. So maybe we missed some or,
Right.
So we give them a PET scan if we think they might have spread based on how aggressive the cancer looks like initially. And we can find those men earlier on and treat them better. So I had a man who had a little bit of spread into the bone, into the lymph nodes, but I could treat him. And eventually he is off all medications 3 years later. Whereas before, we would have had him on treatment for the rest of his life, eventually would have stopped working,
And it's arrested the
and now it's
spread.
completely
And
arrested and it's gone. Now,
it's not really bone cancer. It's really prostate
press it
cancer
into
in
the bone, or the lymph nodes. And I have him, he had some radiation, he had the treatments, and he's cancer free. And now he may need something in the future, but he gets to live several years without any treatments that are giving him any potential side effects.
But he's vigilant in
Yes.
his follow-up and his visits.
and his wife
testing.
is too, actually.
Yeah. Well,
His
that's a
wife
very
is
interesting
vigilant.
thing, and I do want to talk about that. For all of the men that I know, this is not a subject they like to talk about. Confronting one's own mortality is
Right.
never something that the men in my life have ever, they're not comfortable with.
Right.
And it is true that women will push and handle and make sure that people get to where they need to go. Their husbands, their spouses, their brothers, their fathers. What's the message you want to tell men? If we're going to talk directly to men, and then what's the message for the women too?
So it's funny when I've given community talks, it's mostly the spouses that are there, and they bring that home with them. So don't worry about the uncomfortable exam. If it happens, you'll be asleep.
Okay.
And in terms of the side effects of treatments, it doesn't happen to everyone. We're much better at managing those. And we have very much better data on curing men or controlling the disease. So hopefully they can live a normal life expectancy without this affecting them.
Okay. And for the women?
So be vigilant. The husbands, again, men are worse at going to the doctor. Women are much more used to going to the doctor at younger ages.
Yeah.
And to get them in by 50
Is the key.
because you hate to see when the man has his first PSA check and it's super high and is already spread, where it might have been caught 5 years earlier
Right.
if he had just gotten a $30 blood test, which is
Right.
covered but cheap to the system, but can have a major impact on their lives.
Yeah. Wow. I'm thrilled to hear all of this. for my brothers, my husband, and all the men that in my life that I care about, because it seems like you've gotten to the point where you can really be specific about the type of cancer, the way you're dealing with it, the plans for everyone, very individualized. I think this is such a different world from the one that I had been exposed to.
Sure.
So I'm very, very grateful that you came in today
Sure.
and talked to us about that, and really appreciate your time. So thanks for being with us
course.
today. And also to our audience, I would like to acknowledge the partners that we have in our community that help us get our podcasts out to the community and to many groups out there, including the Yonkers Public Library, Yonkers Neighborhood Naturally Occurring Retirement Community, the Ashling Irish Community Center, the Department of Veterans Services, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, Community Baptist Church, Greenberg Parks and Rec, Hastings and Irvington Community Centers, Westchester Jewish Community Services, and Yonkers Pathways to Success. So without you and your help, we could not get the word out about these great physicians that we have here and the great services that we offer at St. John's Riverside Hospital. So thanks for being with us, and we'll see you again real soon.